Hi, everybody. Thank you so much for joining us tonight. So hello, everyone. Thank you so much for joining us tonight for our webinar, What is Immunotherapy? I'm Teresa Blondin, the Manager of Volunteers and Community Programs for Bladder Cancer Canada, and I'm so happy you're all here tonight. We have our National Fund Development Manager, Shasta Boshoff, on the call, and also Michelle Calero, our Executive Director, on the call as well. So part of Bladder Cancer Canada's mission is to provide education to our community. And this session is so important because immunotherapy is often a common treatment for bladder cancer, but there's so many questions around it. So we're very grateful for Dr. Lalani for joining us today. Dr. Lalani is an assistant professor at McMaster University, a medical oncologist at the Javelinski Cancer Center, and an active member of our BCC medical community. We're so happy to have him here today to teach us more about immunotherapy and how it's used to treat muscle-invasive bladder cancer. So welcome, Dr. Lalani.
Thanks so much, Teresa, and the whole team. Really appreciate the invitation to chat with the group today regarding essentially what is immunotherapy in bladder cancer. So I want to keep this hopefully simple enough in the sense that we're able to ask questions later if you'd like. Obviously, I'll review some of the data, which maybe some of you are aware of, just about the role of immunotherapy in bladder cancer. And I guess the only caveat we just discussed prior is happy to answer questions you have along the way about your own personal care plan for your cancer, should you have one, is probably something, well, it's certainly something I can't get into detail. I'm sure you understand for a variety of medical legal reasons, but certainly happy to answer as many questions as we can. So Teresa and the team, if this screen is visible, I'm just gonna move forward. So again, thanks everyone for joining today, and hopefully this will give you a chance to ask some questions and think about things, because really it's been an exciting, I would say, last few years for bladder cancer. And really, you'll see on the title slide, I've called it urothelial cancer. We kind of simplify it down to bladder. Folks may have cancers around the tract. So I just wanted to keep a term that reflects everyone who may be joining. These are my disclosures, none of which are directly related to this presentation I'm going to give you today. So agenda is pretty simple. What is systemic immunotherapy? How does it work? We'll try and distill this down into really basic first principles, and then we can build upon how we apply this directly into why we're all here today, which is advancing the care for our patients with urothelial cancer. And I think specifically what we might do is start, as most of these advancements do, into the advanced or metastatic space. So if you hear those terms used today interchangeably, and I'm sure this group is very well aware, but I'll just keep it as a disclaimer off the hop that this is generally considered for folks who have either a disease that's come back or has started off spread or cannot be removed. So it's kind of advanced or metastatic is the way I'd frame that. That's where much of the excitement of immunotherapy has happened for urothelial cancer. And then we will talk about the real excitement that's come recently on adjuvant therapy. I'll explain what that means, but essentially it's therapy after surgery to remove your urothelial cancer. We now have immunotherapy options after that. Very exciting. And then again, we'll carve out some time. I won't be too heavy on slides to answer any questions folks may have, because it's a really exciting time in the world to research and think around urothelial cancer. And certainly I think patients have been benefiting. So without further ado, let me just dive in with some basic discussion points around what we're talking about in terms of urothelial carcinoma. And I know this is a well-educated group, but just to point out that these are generally felt to be cancers that rise along the epithelial lining of the urinary tract. So you see a diagram here. The renal pelvis, the ureter, this is the tube that really connects the kidney to the bladder. The bladder and the urethra are lined with transitional cells. So cancers along this tract are generally considered together as urothelial carcinoma, or there may be some variants of that. Historically, we've seen the predilection to be more men than women. I think that's been based on decades of the epidemiology or the usage around smoking and other types of work exposures. This is so far preserved, but is shifting a little bit. It is a median age of, again, advanced diagnosis, so not localized disease, but the advanced setting generally is folks who are a bit older. There's some risk factors, which I won't belabor, but essentially if something irritates the epithelium or the lining, this can at some point lead to a cancer. And it can also affect the field. So if folks have a cancer here, it's important to look up the ureter and see if there's a cancer somewhere else. Or similarly, if folks are found to have cancers in the upper tract, let's say renal pelvis or in the ureter, it's really important to look and make sure, is there another cancer hiding out in the bladder? So, this whole concept of looking at the whole field of this urinary tract is really important. So we talk a lot about staging in cancers. So those of you who are caregivers or have had this disease themselves may have heard a lot about T staging. So again, I'll keep it simple, but just to say that generally when we talk about bladder cancer, now focusing on the bladder, largely there's three ways to put this disease in buckets that make it, I think, more practical to discuss. The first bucket, which is the most common, is superficial disease. This is largely called non-muscle invasive bladder cancer or urothelial cancer. And again, this is the TA, the carcinoma in situ, and T1. So if you can see my cursor here, it's these types of cancers. These are the non-muscle invasive superficial disease. That's not really going to be the focus of where we are using immunotherapy at this time, but you can imagine this field is largely moving, and so there will be trials looking at the space. But this is the majority of folks who are diagnosed at this early stage. Once it invades this muscle layer, right? Muscle surrounds this bladder, as you all know well. This starts to move into T2 or greater, and this is where we get into muscle invasive. Therapies here generally, and I won't focus on that, but things like radiation or surgery largely have been the standard of care in the surgical view, at least in North America, is how we treat muscle invasive disease. I'll come back to this later as to where immunotherapy might play a role. And then unfortunately, if a situation exists either at the start or with cancer coming back, that it has come back and spread, again, metastatic disease, what we call stage 4 setting, this is largely what a lot of advancements have been made. Understandably so for folks who are at the most critical part of their disease journey. This is where we see a standard of care for immunotherapy. So again, if there's questions about this, we can talk later, but let's focus and shift a little bit into what treatments we had for metastatic disease, and then we'll work our way back into what we do for muscle invasive disease. So you can see data from now over 20 years ago set the stage for using chemotherapy. And this talk will not be focusing on chemotherapy, but you can see that folks who get the first treatments or first line treatments for advanced urothelial cancers, and let's say it's bladder cancer as the source of it, there are outcomes that we see with standard of care chemotherapy. Now, I'll just point out things to consider are when you get chemotherapy, if it's platinum based, there's cousins of this platinum family. One is cisplatin and one is carboplatin. They're used relatively interchangeably in the advanced setting, but this has been the standard of care for a long time. The first drug you get, IV treatment for advanced cancer, would be platinum based. This was really the standard, deciding first, can a patient safely receive cisplatin, or if not, they would get carboplatin. And then unfortunately, if the cancer were to grow or progress later, after platinum treatment, there might be a need to use another treatment after that if a patient is suitable, and largely that had been another type of chemotherapy. So this was really it until about 2015, 2016. And all of that changed with immunotherapy. And this may be old news to this group, but it's worth noting the history when we think about how do we predict future advancements in this disease. So I put this chart just to kind of set up the stage for talking about immunotherapy. This is a plot with different cancers about the mutation frequencies. These are acquired alterations that we're all acquiring as we live and exist as human beings. We acquire alterations along the way. And so folks who have a diagnosis of cancer were able to see what's the kind of frequency of these alterations. If you look at globally melanoma or globally thyroid cancer or globally bladder cancer, where on the scale of other cancers are these alterations? And this is just to show that if you see bladder put in the box here, this is kind of towards the right of the scale. This is the higher end of having alterations. There's a horizontal line here that kind of captures the middle of this so-called box. But you can see that these are all cancers, but the relative somatic mutation frequency varies amongst cancers. So there's something about lung cancer, melanoma, bladder cancer that has high mutational burden, okay? This is not something I think folks need to worry about too much from what is my number of mutational burden to dictate therapy, but it lays the land for why we think immunotherapy works well in some of these cancers, because there's lots of alterations. Now, how does that tie into immunotherapy? I'm going to take some time to talk through this. Again, if you've heard about talks around immunotherapy, maybe for some of you, this will be a known knowledge, but this is kind of the way some of us can talk to our patients to explain the first time they may have heard about immunotherapy. So this is a very simplified diagram that is trying to show the interaction between our immune system, this lymph node, let's say, and cancer. So what happens generally is that in our body, if a cancer exists, there's a release of antigens, okay? Particles that are floating. And our body's job is to recognize which particles don't look like ourselves. So there's these cancer. So again, a virus could have a particle floating around, and cancer cells will have antigens floating around. And so there will then be presentation. There will be circulating antigen presenting cells in our body that will pick up and present to our immune system and say, aha, here's something foreign. Here's something that looks different than someone's own immune system. This looks different. So this is presented. Now, when this is presented, we get our immune system that really gets primed and activates. So this is this step 3 here. Well, now that we've primed and activated our immune system against this foreign pathogen or particle that looks like an abnormality, like cancer, well, immune cells then go down a highway, our blood vessels, to get to the cancers, because we know what they look like. The cells are presented to our immune system. Our immune system is trying to ramp up the fight against this foreign particle, in this case, a cancer cell, goes down blood vessels. Now it gets to the front door of the tumors. It's got to pass the bouncer. So it's got to actually get through that door. That's a whole process. Then once it gets through and hits the tumor bed, it's actually got to recognize, the T cells have to actually say, aha, there is the cancer. And then there's a killing of cancer cells. Again, this is what's called the cell immune cycle. Okay, very simplified, lots of research over decades that went into this. Now, this is naturally what our body is doing. Obviously, we don't want our body always supercharged and always on. Otherwise, we're worried it might attack ourselves. But there are checkpoints to calm this process, to say, hey, okay, this doesn't always have to be revved on. You know, we don't always have to like hunt and attack our own good self, so to speak. So we have checkpoints that calm this process down. But what if you wanted to release these checkpoints? What if you wanted to say, no, I don't want this calmed down. I actually want this ramped up. And so this is where we have current cancer immunotherapies that help us do this. So how does that happen? Well, drugs that are called PD-1 or PD-L1 inhibitors, you might have heard of Opdivo or nivolumab, Keytruda or pembrolizumab, and there's lots of other drugs here. Again, this is not about being specific to only one drug. I want to talk about the family of drugs that are similar, to be fair. But these PD-1 inhibitors, their job is to take the cloak off the cancer cell at this kind of level or spot in the cell immune cycles. Remember, this was where the T cell should be recognizing the cancer cell. Now, the cancer cell does a great job of evading this whole process. And one thing they do here is they keep a cloak on themselves, say, hey, nothing to see here. I'm not a cancer cell, guys. Just ignore me and move on. So the neighborhood watch moves on. But the PD-1, PD-L1 inhibitors take the cloak off the cancer cell, and now your T cells can say, aha, there it is. So that's pretty cool. That would be nice to have. And that's really, again, very simplified, a couple decades of research, but that's essentially this ability to take the cloak off the cancer cell to lead to better recognition of T cells to cancer cells is what these drugs kind of do. Now, remember I told you earlier in this process that there's a priming and activation of immune cells. What if instead of calming that process, right, the checkpoint that says, okay, we can chill out, we don't need to prime and activate too much, what if we took that calming mechanism off and just put the foot on the gas pedal? That's what drugs like Yervoy or ipilimumab, CTLA-4 inhibitors do. Now, you might say, well, I know bladder cancer treatment pretty well. I've not heard of this drug being standard yet. And you are right. It's not standard of care yet. I also treat other cancers of that tract, so not just bladder, but also in the kidney. And so we have neighborhood cancers that have this treatment as standard of care. And so we are evaluating this in folks with bladder cancer. More to come, but this is, at least in theory, you understand that there's more than one type of immunotherapy. Now, why did I put drugs like this? These are, this acronym is essentially VEGF, or vascular endothelial growth factor, the factor or the receptor directed therapy. I won't belabor this because, again, it's not routinely standard of care for all patients, but we've had lots of clinical trials looking at this over the year, and there's more coming. I'm going to mention one drug. Again, it's not to pick a drug. There's been lots of studies. Sunitinib, pazopanib, lenvatinib have all been studied and are undergoing future study. Cabozantinib is one example. Now, why this is helpful, why I brought this up, is because we're seeing this in other tumors, but I think the aim is to study this in bladder cancer, and I'll come back to this whole story in the end, is that, okay, you've primed the immune system, you've hit the gas pedal, okay, supercharged. You've then taken the cloak off the cancer cell. What if we could do a better job of making the highway more permissive? What if we do a better job of trafficking T cells into this microenvironment for it to work? Well, that's where we think if we give drugs like these targeted therapies with these other immunotherapies or combinations thereof, this can even make this whole cycle even more favorable for a patient's own immune system to be ramped up to fight cancer. So I took some time on that. If this is all old news, I'm really glad to hear that. And if this just helps you understand a little bit better, then I'm really happy too, because I find that when I'm in my clinic and I discuss these types of treatments with patients, caregivers, families who are really excited to hear more, because this is all Googleable. It's really interesting to see commercials about this. I want to make sure patients really get it, because God forbid, but if they ever had to seek medical care in between cycles or call into cancer centers or present to the local emergency department, and we'll get into side effects later, but if the patient knows at least the name of the drug they're on in detail and kind of understands what the drug is doing, really helps build that relationship amongst the caregiving team, but also I would say when the patient needs to mention to someone else, hey, by the way, other physician who's not my regular oncologist, just so you know, I'm on this drug and this is how it works. Because remember, for so long in bladder cancer, is just IV treatment meant chemotherapy, but clearly that's not the case. IV treatment now in bladder cancer means many types of options, but it's standard of care to have immunotherapy. So that's the nuts and bolts of really what immunotherapy is. And you can apply that knowledge to other cancers that use immunotherapy. That's not just bladder cancer knowledge that you'll get today. That's kind of general cancer immunotherapy knowledge. So hopefully that was helpful in some way. Now, let's go into the first foray of where immunotherapy was used for. Again, I'll say bladder cancer, but you can see how all the publications use urothelial cancer, and you understand where in the urinary tract we're all trying to be all-inclusive. Published in New England, 2017, the KEYNOTE-045 study. Very briefly, this was again urothelial carcinoma, renal, pelvis, ureter, bladder, or urethra. This trial was built for patients who, remember I told you, had previously had platinum, and then all we did was go on to another type of chemo after. Well, this trial tried to say, well, how about instead of going everyone to get chemo, we randomize patients to go from their previous chemotherapy, and unfortunately the cancer has grown. They get randomized to immunotherapy or chemotherapy. This is a clinical trial. This is the hard work that needs to be done before treatments can become standard for folks around the world. So this trial was done in this way, randomized about 540 patients. And what we saw is this is, very typical. Look at patients could have been up to age 88. That's your take home, is that, age doesn't necessarily dictate whether a patient is eligible for treatment, because I treat a lot of folks into their 80s and 90s. And everyone's chronologic age and their biologic age can be a little bit different. So again, these were mostly patients who had good performance status. You might see your oncologist ask you questions about your performance status, trying to understand what is your ECOG performance status. And so anyways, these are the baseline characteristics for the trial. But I think the real punchline is that when you look at the group that got the immunotherapy after their prior platinum, or the group that got another chemotherapy after the prior platinum treatment, folks who got the immunotherapy live longer. Now, the median just looks at this 50% mark, right? But you can see that the chance of being alive at 1 year, if you got immunotherapy, was 15% higher than if you just got chemo as your next option. And then as you got to 2 years, 9% higher. These are things that patients kind of want to know, like, doc, what's my chance of being alive at 2 years if I take immunotherapy versus chemo? So at the time, this was still a question that needed to be tested. But now you can see that we're very fortunate. It's the standard of care. And as you can imagine, folks who have a lot of shrinkage of their cancer, their lifespan would be even better. So the difference between the curves is even better. Even if your cancer, when you receive treatment with immunotherapy, just stayed stable, did not grow, because cancer's job is to grow, that even that, having stable scans, still meant you lived longer by getting immunotherapy versus chemo. So that's really why it's become the standard, where we seek indications from, for example, Health Canada. We seek for endorsement and approval across national agencies, and then essentially make it publicly available. Taxpayer funded immunotherapy, it's a standard of care. So this is a tornado plot. I don't want to go through this in detail, except to say these bars tell you the experience of patients on clinical trials who had these side effects. More bars or longer bar means more side effects. And then there's shadowing here for high grade or lower grade. If you have ever been on a clinical trial, certainly I treat a lot of patients on clinical trials. It's our job to document this, because when the publications come, so much depends on what each investigator and the trial team, the trial nurses document. So it's really important. We're super particular. But you can see that the shadowing of these bars is far more side effects for chemo than immunotherapy. So there's your experience on treatment, not just lifespan, but the patient experience in terms of side effects, or what we call toxicities, is less on immunotherapy, which is great. And then the other part of these kind of trials, and this is kind of, I think, a general comment about immunotherapies as a whole, the quality of life score. So again, if you've participated on clinical trials, you might, and we're certainly grateful when patients do, but you might get the trial coordinator saying, hey, here's a survey for quality of life at this check-in time point. Can you please answer these questions? And we find as a whole, patients who receive immunotherapy versus chemotherapy on that clinical trial had a better quality of life experience. So now you got treatment that helps folks live longer, feel better, and have less side effects. This is why it should be, I think, standard of care, and it is. So that was the lay of the land at that publication, 2017, 2018. Now let's get to 2020. How do we change? How do we get better than saying, give chemotherapy, and then if the cancer grows at a later time point, give immunotherapy? Okay, standard of care in an advanced or stage 4 setting. So the way we did better as a collective we, the global bladder cancer research experts, communities, clinical trial researchers, really patients and their families, all of us coming together to try to advance care, was this next trial, the JAVELIN Bladder 100 study. How about, instead of giving a patient chemotherapy, finding shrinking or stable cancer, and then just waiting for it to grow, how about if the patients who got chemotherapy had stable or shrinking CT scans. Basically, the cancer has stayed stable or shrunk. Instead of watching them, which is best supportive care alone, that's what BSC stands for, okay, best supportive care. You know, pain management, nausea management, all these kind of supportive measures. Instead of doing that alone, how about we just immediately gave them immunotherapy? How about we did not wait until the cancer shrank and then grew later? How about even if it shrinks, we give immunotherapy right then? So that was this design. Folks who got chemotherapy randomized to what the standard was at the time, or going immediately onto what's called avelumab. This is given IV every 2 weeks as another cousin immunotherapy from what I just showed you. And really the punchline of this trial was that folks who took that approach, who got the chemo and then said, okay, I got the chemo, I realized cancer shrunk, this is fantastic news, but going on to immunotherapy is the right thing to do. So folks that got randomized to that arm actually found that that these patients live longer than folks who got randomized to say, hey, the standard of care is just to have my chemo and then recover and feel better and wait for it to come back. That even those patients, even if they got treatment when it came back, it still was not the same as diving in with treatment up the front. So you could see a 7-month improvement in survival is a big deal for an advanced or metastatic stage 4 cancer patient and their family. That's a big magnitude of benefit in the bladder cancer world. And it really didn't matter if you're old or young or what your chemotherapy was prior to going immediately on to immunotherapy, whether the liver or lungs were involved or just lymph nodes, what your kidney function was, all these different types of patients benefited from this approach. And that's why the standard of care is now, once you receive your chemotherapy for the first treatment for your advanced cancer, as long as the cancer has been stable, your physician may talk to you about going on to maintenance therapy. And maintenance meaning, hey, I've got either stable or shrinking cancer, and we don't give more than really 4 or 6 rounds of the platinum chemotherapy. Let's go straight onto avelumab as a maintenance. That's the best approach. So you can imagine what the concurrent or next thought was, is to say, okay, instead of waiting, we give chemo, and if you benefit, straight onto maintenance immunotherapy. Why don't we just do everything together? So that was the next leap, adding immunotherapy at the same time as giving chemotherapy. And again, I won't belabor each of these studies. It's just to mention to you that this was in fact the way things were done. So there was a clinical trial looking at exactly this situation. Your first treatment is chemo plus immunotherapy, immunotherapy alone, or chemotherapy alone, randomized study, because this needs to be tested in a rigorous way. The KEYNOTE-361 was similar. First treatment is going to be chemo plus immunotherapy, or chemo alone. And then the Danube study, again, these were global international phase 3 trials. This one was interesting, looking at 1 immunotherapy, 2 immunotherapies, or chemotherapy alone. So none of these arms combined immuno and chemo, but all these trials were done. All of them have read out. And really the summary on this slide, the punchline is that bundling everything together upfront, chemo and immunotherapy, all upfront for stage 4 or advanced cancer, did not improve the survival of patients compared to if you did the chemo upfront and then, really essentially the approach I just mentioned, which is going on to maintenance immunotherapy. So 1 and then immediately going on to the next, versus doing everything up front together. That everything up front has not proven to be beneficial. There's still some trials pending readout, but that's the lay of the land currently. Now, you may be asking, and again, it's not the main purpose of this talk, is to say, well, what happens? I love this. This makes sense. I understand if my cancer has spread or not resectable, not surgically removable, that this is the kind of approach I should be taking. But what if you use chemotherapy and then use immunotherapy? What else can be done? And there's lots of great options. There's alterations of a certain pathway that we can now test for. There's also a treatment that can be a monoclonal antibody, which means you have an antibody that seeks out bladder cancer cells, let's say. And once it finds it, it is internalized, and then a payload of cell-specific chemotherapy can be dropped off. Maybe that's another way of really attacking bladder cancer after chemotherapy and after immunotherapy. And that's really where the State of the Union is now. So for metastatic or advanced disease, first line is platinum-based combination therapy. I've talked to you about the two combinations. And then if you have a stable CT scan, or even the cancer has been improving, meaning it's getting, shrinking, you switch immediately to immunotherapy as a maintenance therapy, and that's the best chance for having the longest life. If unfortunately you receive this chemotherapy and your cancer grew irrespective, well, luckily we have what's called second line immunotherapy now. Slightly different medications, still the immunotherapy family. This is a PD-L1 inhibitor. This is a PD-1 inhibitor. I think the real takeaway is that folks who get chemotherapy will get a next drug essentially to help them. And that's either immediately if your cancer got better onto nivolumab, or if unfortunately it grew, then onto pembrolizumab. Pembrolizumab in this setting as a second treatment is available and funded, and very pleased that recently, especially in Ontario, has just had this publicly reimbursed now, and I think many provinces have already done this or are soon to follow this kind of approach. I'm talking to you about the switch maintenance is publicly funded. It was available, so but now the public system is paying for it instead of access programs. So this is excellent. And I've just shown you very briefly, because it's again a whole separate talk, is what do we do after chemotherapy or immunotherapy? There's lots of interesting options. And enfortumab vedotin again is available through a program in Canada. If you have one of these interesting alterations in your cancers, erdafitinib is a drug. Again, I'm focusing on immunotherapy, but I just want to point out that there are options for you with an advanced cancer. I mean, there's lots of questions that remain. What if you're not even suitable or safe to get chemotherapy as your first drug? That's where I think we have a lot more work to do. I think we need to find more options for patients who aren't even well enough to start with chemotherapy. There were clinical trials using immunotherapy alone was studied, not reimbursed in Canada. Sometimes it's unfortunately, there's patients are just unfortunately too unwell to get any treatment, but this is a group of populations I think a lot of us, I certainly think about a lot, and we want to try and do better. But again, we've made so many advancements as well. If you're interested in reading more about advanced disease, what to do with a cancer that has spread, that has bladder cancer or urothelial cancer, this is a recorded conversation, but I've just left a citation here. One of my fellows at the Javelin Cancer Center and our incoming resident wrote a great review that we were able to lead and publish, and it really lays out all these different things. It might be quite technical, but I think it really captures the lay of the land of bladder cancer really in the world. So what's coming? What should you be aware of for questions that you might read about or hear about, or your physician may bring to you? So building on that maintenance therapy, remember I mentioned chemo, and then if it stabilizes or shrinks, get onto a drug called avelumab. Well, there's a trial that will be coming in the future looking at avelumab plus cabozantinib. Do you remember how I showed you that there's utility for using oral VEGF-directed therapy? I showed you earlier on in that cell immune cycle what might actually make immunotherapy work even better, or may even be traveling to the cancer better. So that's a trial. So again, similar to what the standard is, if you get chemotherapy up front and it stabilizes, you go on to avelumab, or the other arm will be avelumab and cabozantinib. So again, maybe not for this group, but if in the future other patients unfortunately have a spread cancer that do get treatment, fear not, we have great options, but we have a clinical trial that should be coming to Canada, and we're leading some very provocative biomarker research, blood, the microbiome, and tissue. So we'll be leading that in Canada as part of an international phase 3 study. So really proud that Canada is able to support this. What about other strategies? Maybe you have been enrolled on this trial, or someone you know, or you're just interested. there's lots of ways of maybe using immunotherapy up front. Maybe we can use it instead of chemotherapy. So not together with chemo. We already know that has not proven to be beneficial, but there is other trials that are coming to be reading out in the near future. So again, it's constantly moving. I don't want to overwhelm you with this data, except to say that when the time is right, we'll probably use forums like Bladder Cancer Canada and others to really raise the awareness that, hey, we have another first option instead of chemo if this trial is proven to be beneficial for patients. So more to come. Okay, so a lot of immunotherapy talk. Hopefully that's found to be helpful. I'm going to just use the last few minutes to talk about what we do for adjuvant therapy. Now, this is therapy that's tailor-made for folks who have had a local bladder cancer caught or a upper tract cancer caught and need surgical resection. So what's called a radical, let's say, cystectomy or cystoprostatectomy if you're a man, and then obviously different organs would be removed if you're a female. But what do we do after the surgery is done? Is there anything that can be done to help folks? So what I'm talking about here is this bullet point, the muscle invasive group, that's T2 or more, okay? Let's say you've had your cancer removed. Now you might hear about options available. So very briefly, not to belabor the point, muscle invasive disease, radical cystectomy or surgery is the gold standard. You might have heard, or you might hear about the chance of preserving your bladder in very select circumstances where radiation can be done. Centers like ours in Hamilton at McMaster, certainly Toronto, Montreal, and I think other centers across the country have expertise in treating bladder cancer with surgery or radiation. So we have clinics that, for example, I attend at a clinic that is called our multidisciplinary bladder clinic, where patients who come in with muscle invasive bladder cancer meet a surgeon, a radiation oncologist, and a medical oncologist all in the same sitting. Seems like a lot, but you get 3 gold standard opinions right off the hop, no delay. Patients can hear about all the options available, and then we work with a care plan in highly specialized centers to make sure we know who is carrying the football first for the patient's care plan based on the recommended or chosen option. So very, very cool clinics. But essentially there's a group that might be suitable for bladder preservation. Now, it's really important that we don't forget that chemotherapy around your surgery, ideally before your surgery, is the standard of care globally. There might be some patients who aren't well enough to get chemo prior to surgery, get the surgery, recover, and can get chemo after. So that's the so-called adjuvant. So this is the chemotherapy piece. But there are questions that remain for muscle invasive bladder cancer. What options are there for patients who are not suitable or fit enough or well enough or decline chemotherapy before or after surgery? Let's say you had your surgery, but no chemo before or after. That's one question. The other question is, what about for patients who, let's say, had chemo prior to surgery, went on to surgery, but after the surgery is done and the pathology report is being reviewed, that there's still high risk or worrisome features on that removal of the bladder? There's still some concern. Is there anything we can do for those patients? And you can tell by the way I've phrased it or intonated it that yes, there is. So there is immunotherapy. Now, I'll keep it very simple. There's been 2 trials, a little bit different. One was taking exactly what I said, patients who got chemo and then a radical cystectomy, or patients who never got chemo but did get the radical cystectomy, had high risk features. Some after the surgery were just observed, which was the standard. The other part of this trial got immunotherapy. Now, this treatment did not end up showing a difference between the time for the cancer to come back. Okay, but there's another trial that was done, presented now about a year ago. And this was a trial, again, same kind of setting. Folks who have had a radical cystectomy or bladder removing surgery for muscle invasive bladder cancer, who had chemo prior, but still had very high risk features, or never had chemo prior. Now, this trial looked at using nivolumab, that PD-1 inhibitor, versus placebo. In this trial, it's already done. Published data shows that if you get the immunotherapy, This curve is higher up, doing better, meaning that the chance for your cancer remaining disease-free is longer if you get 1 year of immunotherapy rather than just watching and waiting for it to come back. So that's a big deal. I mean, we cannot look you in the eye right now and tell patients that this approach will help folks live longer. And I think all of us want to see that data. That data will come. We will see if that difference is there. But at this point, to have a big gap between the cancer coming back or not is, I think, for many patients, an important discussion. So hopefully we've built this stage for the majority of this talk on immunotherapy, the advanced setting, and then where we could use it after surgery when it's not spread. I just want to briefly touch on what we think about in our clinic when physicians, our trainees, our nurses talk to you about immunotherapy and the side effects to watch out for. So, there's chemotherapy. What does it do? It's very good. It's like napalm. It kills fast dividing cells, good and bad. That has its own side effects. Then the oral pills or targeted options have certain effects. Immunotherapy, by now you're experts. You can teach people about immunotherapy. It ramps up your immune system to fight cancer. So the side effects of that might be that the immune system gets so excited that it starts to attack yourself. So it causes autoimmune or immune-related adverse events or side effects. So how do we help provide excellent care for patients who are about to embark on immunotherapy? It requires a really good baseline assessment. So, bear with us if your physician or the team or the nurses asks you all these questions. What is your breathing like? What is your skin? Do you have rashes? What is your bowel function like? We need to know that. We need to know. We'll check your thyroid, your liver enzymes, just to make sure before we start treatment with immunotherapy that we know what the lay of the land at a baseline is. Then we'll want to make sure patients are educated. A lot of my job as an academic oncologist in a teaching center is to make sure our multidisciplinary teams, both locally and then really regionally and then provincially, folks like our pharmacy team, our trial nurses, our nurses, our local emergency departments, get their education through events like this and others that we direct towards them to raise the level of understanding for all folks in the healthcare system about what immunotherapy really means and what it can do. And so we have all at our major centers have gastroenterologists who know what the GI side effects of immunotherapy might be, hormone specialists, skin doctors, lung specialists, eye specialists. If we are really worried about a side effect, we got to have specialists that can help us investigate that body organ or that body area that we're worried about. We will monitor, it's very important, these immune side effects can happen anytime. Your immune system is ramped up, it is ramped up. I try and tell patients that sometimes we start the immune system, it's like lighting a huge campfire. And sometimes the treatments we give once in a while are just help to keep the coal in that fire, or keep that fire burning. So, sometimes your immunotherapy might stop, but your body will still benefit because the fire has been lit. Sometimes we need to stop and calm the immune system because it got too excited and it got ramped up, and everybody's body is different. So again, these are very simplified terms, but we can get very technical about the things we're looking for. And so, these are all the different things that can happen because the immune system can affect everywhere. But again, to limit this being an issue, we educate patients, make sure they know how to call for certain things to look out for. And then if it were ever to become a problem and say, well, these are the symptoms, we might ask you about your shortness of breath. I will get really nitty gritty about how many bowel movements, and if it gets above a certain amount, we need to hear about this. Any cancer therapy can cause relatively vague things like fever and fatigue, and that doesn't always tell you exactly what's going on. Then we check blood work. It's really, really important because most folks can tolerate this treatment quite well, but it's our job to catch on to things that sometimes are unpredictable. Now, the reason we do all of this is because one, well, we've shown you the data for the benefit of immunotherapy, but also managing the side effects are fairly doable for most patients. We just have to start something that calms the immune system down, and that is something like steroids or corticosteroids, okay? So this might need to be oral if your treating team, obviously we don't want our patients to have side effects, but it may happen, and it may actually mean your immune system is really nicely revved up. We may need to give you IV steroids or get you to see one of our colleagues who's a specialist in, let's say, liver or lungs outside of cancer care, but dealing with the side effects of immunotherapy. So we are generally in these major centers all aware of who we go to in these situations. There's lots of great clinical practice guidelines. I don't think it's something that this group needs to worry too much about, but your caring team, your physician and nurse and trainee team and everyone together, really, we have great guidelines in Ontario. There's lots of provincial guidelines across each province because immunotherapy is so widespread across cancer care. So I want to leave some time. I'm going to stop. This is my last summary slide. I hope this was helpful. Maybe you picked even one pearl out of this. I hope it wasn't too confusing, but again, it takes time to understand this. Hopefully this laid the land a little bit. So my summary for immunotherapy in urothelial cancer is that, really for a spread cancer, platinum-based treatment, and then that immediate switch to maintenance immunotherapy is the standard of care. It helps folks live longer. For folks that can't get any chemotherapy, I think this is where we need to find other options. I think you've seen now the evolving story, this exciting story of taking immunotherapy from just the spread setting to the localized setting. So adjuvant nivolumab for high-risk patients post-cystectomy. There is an access program available through BMS, manufacturers of the drug. I have patients who are already receiving nivolumab after their surgery. So again, if you or someone you know has had a bladder cancer, bladder removing surgery, there are options to receive immunotherapy. I think patient education, early recognition of adverse events can help us make sure we optimize the benefit and limit the side effects of these drugs. And then look, there's going to be lots of excitement. There's already immunotherapy starting to be tested in smaller trials or smaller experiments earlier on, even in the superficial setting. It's not quite standard yet everywhere, but it's going to come. And I think there's some real excitement about where immunotherapy can exist. So thank you so much for your time. I hope you found that helpful. And I'm really pleased to answer any questions you might have.
Well, thank you so much, Dr. Lalani. What a great presentation. It's so amazing to see the advancements in treatment options for cancer patients, especially treatments with less side effects and better quality of life. So thank you again. We will now open the floor to questions. So please use the raise hand button if you would like to ask a question live, and we'll unmute you, or you can use the Q&A function as well, and we can read out the question for you.
This is a question for Dr. Lalani. I was involved in a clinical trial with Durva from 2018 to 2020. That particular clinical trial has produced some remarkable suppression effects. And the question that I have for Dr. Lalani is actually twofold. Number one, apparently Durva is not available in Ontario because, as I understand it, even though the federal health agency has approved it, the Ontario agency will not fund it. Secondly, there's an issue as to whether a booster might be useful to have as a follow-up. And there's apparently some debate as to whether a booster is even useful because there's no research on a booster. And finally, the question is, if Durva is not available, do I go back to Pembro? Question mark.
So thanks, Matthew, for that. I just want to make sure that I understood the context perfectly now. The durvalumab that you mentioned, and for folks who don't know, but this is, again, a PD-L1 inhibitor, a cousin for immunotherapy. Was that in a setting of a spread cancer? So I mean, second line post-chemotherapy, or in, can you recall what setting that was used in? And then I can answer the Ontario availability piece, but I want to make sure I understand in which setting you were receiving Durva.
The treatment plan started with bladder preservation. It began then with high dose chemo platinum chemo, cisplatin, and 4 other chemicals. That went on for a period of about 3 months, followed by radiation that went on for about 4 months. And then in about 8 months, we detected cancer cells outside the bladder in the lymph nodes. So Durva was I enrolled in the Durva clinical trial at that time, and that's where I went. I hope I answered your question.
No, you nailed it, because there's, I have to say, Matthew, we have in fact an ongoing trial, which I don't think is the one you're talking about, but BL13. This is a Canadian trial that folks who get exactly what you did, which is radiation for your bladder cancer, immediately after finishing radiation, they get randomized to just watching and waiting or getting durvalumab then. That's an ongoing trial. That's not what you're talking about. What I think you're talking about is you had your radiation, as you said, after already getting chemo prior, and unfortunately there was disease that came back and you got durvalumab. So in that situation, what I would say is that's very akin or similar to what the pembrolizumab indication is funded for, meaning that you've had some form of therapy for your bladder cancer. Unfortunately, a cancer has come back, and if it's within a certain time window of getting your first chemotherapy prior, you could go to immunotherapy right after. So I would say that if you got benefit on that treatment, that's great. I think Pembro is certainly available, and without knowing the exact details, I would say that, certainly this is one where you could discuss with your team as to, okay, now in my situation, what can I go to? I would say you're correct that durvalumab in the post-chemotherapy context in Ontario has not been funded. Now, the reason for that is that I just mentioned we have access to pembrolizumab in this province after chemo. So the feeling that there should be multiple drugs approved in the same indication was probably not felt to be helpful. Sometimes industry can pull their applications. Sometimes it's not fought for because there's already a fully funded option available that is essentially cousin. What I will tell you is that if there is an indication where durvalumab provides unique benefit, we would in Ontario and really across Canada fight for that approval. I think in this situation, if I understand correctly, that after definitive treatment, cancer came back, there was a need for another treatment. I think we do have a drug like Pembro in that context. Now the booster, I want to make sure you're talking about booster of immunotherapy. Is that what you're talking about?
Well, the theory has been, as you know, in North America, the generalized previous response was surgery. However, in Europe, that has not necessarily been the general response. It's been bladder preservation. So after you participate in a clinical trial using one of these inhibitors, which I did for 2 years, then essentially you're in a wait and see mode. And you're tested on a CT scan every 6 months.
Yes.
The question I raise is, why not have a booster?
Great question. So in fact, we have tried to study this across other cancers, which is, as you say, I had a time period X of immunotherapy. I clearly gained benefit. The time period of 2 years in bladder cancer is very well known that at that point, further immunotherapy, like I said, that fuel for the fire is probably already burning enough in your immune system after 2 years. You don't need more. You're asking, why can't I later, if there's growth, re-challenge, add it back to the cocktail, boost my body again? And so we've tried to study that. And I think the short answer is, again, without getting too academic, is that we need to test that to prove to patients, not just funding authorities. It's always about patients first. We need to prove to patients that this actually helps you instead of going to the next option available. And I've tried to show you that there are other options. So the short answer for you, Matthew, is that there are options after immunotherapy available. But we need to prove that reboosting or re-administering the immunotherapy with all its particular side effects actually is worth it. Because there is an opportunity cost about not going to another treatment and what's best for someone in your situation. So those trials are trying to be conducted. We've looked at that in kidney cancer. We're looking at that in other cancers as well. So short summaries. I wish I had a punchline for you, but it is pending further analysis to see if that's helpful. But again, if you have finished immunotherapy, it would be worthwhile to ask your oncologist if it's been enough time window that you could re-challenge with. If it has been a long enough window, could we go back to immunotherapy given, for example, I used 2 years, and let's say there was 1 year after where there was no issues, and then could your oncologist team avail of getting pembrolizumab in this setting? I think that's a very fair question, because I remember you asking that. If that's not deemed suitable, and again, I don't want to personalize it just about your care plan, but I want to say in general, we could avail for folks to get another type of treatment like I showed earlier. So very interesting case that you have, and hopefully you'll be able to, while we as a global community try and answer these provocative questions you've raised, be able to get some clarity on what's available for you in Ontario. But you're right, durvalumab as a drug is not part of standard of care, but there are cousins.
Thank you.
And thank you to Dr. Lalani for this amazing presentation and your willingness to share all of this information with our community. Thank you, everyone. And I hope everyone has a great night.
Thanks, everyone. It's a pleasure, and take good care.